Hi everyone, and welcome to Intravenous Therapy. Some of the advantages of intravenous therapy are rapid effects, which bypasses the GI system and goes directly into the bloodstream, precise amounts. This is where the drugs such as pain medication or doses based on weights come into play. There's also less discomfort after the insertion. So you have the pain on the initial stick, but then after that it's more comfortable for the patient. And that's opposed to getting an IM injection every 8 hours. You can now get an IV injection every 8 hours, and there's less pain associated with that. You have less irritation to the subq and muscular tissue. Like I said, you're now receiving the medication IV as opposed to subq or intramuscularly. And there's also constant therapeutic blood levels, so you can give seizure medications IV over a period of time, and that will build up those therapeutic levels in the patient's system. And it's also the preferred route of administration for irritant medications such as your chemotherapy drugs. So just like advantages, we also have disadvantages. For instance, with circulatory overload, this is when the patient's receiving IV fluids too rapidly. Their body can't adjust to that rapid infusion. They may have congestive heart failure or pulmonary edema as a result of that fluid overload. There's little time to correct your error. So you always have to make sure that you're very precise and accurate with your calculation, especially when you're given those IV medications, because once you inject it, you cannot get it back. Many of the medications are very irritating to the lining of the veins. For instance, a drug called Phenergan is given oftentimes for nausea. Well, after the patient receives 2 or 3 doses of this Phenergan, oftentimes we're having to reinsert a brand new IV because the other IV is just so damaged and it becomes painful for the patient. So some drugs are very painful and irritating to the lining of the veins. You can have local and systemic infections. For instance, an IV that's infiltrated can come infected. You may have drainage at that site from the IV that's infected just from the site. You could have mishandling of IV fluids and medications. TPN is one of those things that can lead to an infection if it's not handled properly by the nurse. IVs are also costly. When I say costly, whenever you hang a bag of IV fluids and the doctor comes in and he wants to change the order, change the prescription, whatever is remaining in the bag has to be thrown out and a new one started. So that's very expensive. And some of the drugs, antibiotics, some pain medications, chemotherapy drugs, these are some very costly and very expensive medications. As far as the inconvenience, it's very inconvenient sometimes for a patient to have an IV because they have loss of that freedom of movement. And embolisms can also occur. You can have an air embolism that's in the tubing. You can also have catheter embolism. That's where the end of the IV catheter is sheared off and a piece of the catheter is actually left inside the patient's vein. When this happens, you're going to have to put a tourniquet. Hopefully you can slow that down, get a surgeon. You may have to cut the patient's arm open or whatever to get that catheter tip out. But an air embolism, you can't really do a whole lot about. That's going to get in and it's going to make its way. So IV pumps vary from facility to facility. Every place uses a different IV pump. So we all have to just learn to use what's available to us. They're often used for continuous administration of IV fluids or drips. You can add medications in large volumes to give to a patient, so there's a lot of advantages to having a pump. Whenever you're beginning your shift, always assess the IV site, then check the pump to make sure that it's being cleared. So at the end of your shift, you will have an accurate IV intake to document at the end of your shift. If you have a pump that's beeping before the infusion is complete, always assess the IV site first, assess the patient first, then start to troubleshoot your IV tubing and your pump. Look at the tubing, see if the roller clamps are open, see if there are any kinks in the line. The patient could be lying on the tubing, so check for those kind of things. Then look at the pump. If for some reason the pump says the battery may be low or may be weak and it's telling you to plug it in, that can be a source of the beeping. But if you look at the pump and you decide that there is something going on with this pump that you cannot fix, make sure that you remove the pump from use. That's right. Take the pump out of the patient's room, get another pump for the patient, and send that pump for repair. Do not continue to use a pump that could be flawed, because you can have a medication error occur that way. So let's talk a little bit about intermittent administration. So intermittent infusions are also referred to as IV piggybacks or secondary infusions, and they can run in tandem with the primary IV fluids. These secondary infusions contain small amounts of medications, like a drug, that is diluted in a small volume of IV fluids. Usually that volume is 50 to 100 milliliters. So that's what you have with your intermittent infusion. You have a bolus, a secondary, or a volume-controlled set. So this is the volume control set. As you see, it has a chamber in the IV tubing itself, and that holds a small portion of IV solution to which you can add medications to, like antibiotic. So we're going to talk a little bit about medication locks. These are also referred to as saline locks, HEP locks, intermittent locks, or INTs. These are used when continuous infusions are not necessary. When you're not infusing any medication through a med lock, make sure that you flush it with normal saline at least once a shift. Preferably, this is done at the time of your initial assessment. You want to ensure patency for your shift. If you're unable to flush the medlock, it should be removed and another one started. Central lines are often inserted and used whenever we need to deliver a large volume of medication. Clients who require long-term IV fluids, who are receiving irritating drugs or medications, or those who we have difficulty inserting an IV on, they may get a central line. A central line insertion is performed by a surgeon or doctor, a nurse practitioner who's been trained, or a physician's assistant who's been trained to insert these lines. You have to have written consent by the patient or the family member to insert a central line unless it's an emergency. Internal jugular, subclavian, and femoral sites are the most common sites for central line insertion. A pneumothorax is a complication from a central line insertion, and that usually happens when the insertion site is in the jugular or subclavian areas. Make sure that whenever you have a patient with a central line, that you are flushing all of the ports that are not in use. Preferably, you do that at the beginning of your shift when you do your assessment. If you are not able to flush the ports, You then need to follow the policy of the facility and procedure and do whatever the policy tells you to do to declot the line if that's an option. If not, you have to notify the physician that your central line is clotted. A PICC line, PICC, a PICC line, is inserted through the skin in a peripheral vein. You see, it's right at the brachial area, and it can go pretty high up into the subclavian area as well. PICC lines are often used for long-term IV medication therapy done at home. When doing your PICC line care, remember to measure from the insertion site to the connecting end and document the exposed length. This helps to determine if the catheter has slipped out of position or not. Tunneled catheters are inserted into a central vein with part of the catheter secured to the subcutaneous tissue. These are often used for your dialysis patients, and this too is inserted by a surgeon. A portacath device is a self-sealing device that is under the skin. It's surgically implanted, and the port of that device will self-seal whenever you withdraw the needle. So like I said, this is a surgical procedure. This has to be done in the operating room. The device is not visible, so you have to actually palpate the chest area to locate the device before inserting the needle. The needle that we use is referred to as a non-coring needle. Sometimes it's called a Huber needle, and the needle has an angle to it. An intraos or an IO device is a route for delivery of fluid, blood, or medication through a needle that's inserted directly into the marrow of the long bones. This is done with a specialized drill, and it actually drills into the bone marrow, and the needle is inserted that way to administer the medication. Just some safety tips for IV therapy. Always use an infusion pump, especially when you're infusing medications such as heparin or insulin or pressors. Always add medications to a new bag of IV fluids. Never add medication to a container that is already hanging. Never administer IV medications through tubing that is infusing blood products or TPN. Those have to be infused in separate tubing. Verify compatibility of medications with IV solutions before infusing a medication. If you are going to give 2 or more IV medications at the same time, always refer to the drug reference for compatibility. Just a few things we have to consider when IV therapy is in use. Is the patient on anticoagulants such as heparin or warfarin or Plavix? Are they on some type of blood thinner that can cause them to bleed whenever you remove that IV catheter? Always know that edema and obese patients are going to be a little bit more difficult to stick. That IV is going to be a little bit more difficult to insert. So you have to be patient with those types of clients and just take your time looking for an IV site. But know that you may have difficulty when you have these types of clients. This is an example or just a picture showing you of the most common peripheral IV sites in a patient's arm. So you have to be very familiar with complications and what are you going to do to treat it as a nurse, or what can you do to treat it as a nurse. So whenever the client is receiving IV therapy, they should be free of any complication. If a complication is occurring or suspected, you need to stop the transfusion. Infiltration. When you look at infiltration, which that's an example of it, the picture that I have up for you. Infiltration, you'll have pallor, swelling, tenderness, tight feeling. Discontinue the site and elevate the extremity. Warmth can be applied for comfort if it's not contraindicated. Extravasation, this is with the use of a vesicant or a cytotoxic drug, which are your chemotherapy drugs or your pressor drugs. If you have something like that infusing and you have an infiltration that occurs because of that, you need to first stop the medication, discontinue the infusion. Step 2, follow the facility policy when it comes to a vesicant infiltration. Step 3, notify the MD that you had a vesicant or a cytotoxic drug infiltrate, because you may need a doctor's order to inject some type of reversal drug to stop any necrosis that could be happening. Number 4, implement the orders that you get from the physician. 5, document all signs and symptoms and treatment you provided to the patient. And 6, monitor the client and give a detailed report to the oncoming shift. If you have a patient that develops a hematoma, elevate the extremity and monitor it. If you have a catheter embolus, depending on where the embolus occurs, you may be able to put a tourniquet on it and notify the surgeon. Then again, if may not, just depends on how high up or where that catheter tip is located at. If you have phlebitis or cellulitis, you may have to give the patient some antibiotics. That may have to happen because that's an infection that could occur. Fluid overload, you're going to stop the IV fluid immediately, call the doctor, let them know that the patient's having some respiratory trouble, give them some supplemental O2, a chest x-ray may be ordered, and a diuretic such as Lasix may be given as well. If you have IV solution that require refrigeration, be sure to set that medication out at room temperature for at least 30 minutes prior to giving to the client, because you don't want to give cold IV fluids to the client unless you're treating a certain disorder, but you don't want to give cold IV fluids. So you want to warm that up for the comfort of the patient. We have 3 different types of IV solutions that we give. We have hypertonic, isotonic, and hypotonic solutions. So your hypertonic solutions cause the cell to shrink. Your isotonic solutions are your equal or your same concentration solutions. And then your hypotonic solutions cause the cells to swell. Commonly, we give the 5% dextrose in saline. You'll hear it called D5 normal saline. That's the most common hypertonic solution we give. There are some cases where we give some 3% saline, but that's under extreme circumstances, and that's given in the ICU only. But out on the floor, when you're on the medical floor or the telemetry floor, you're going to see the D5 normal saline or the D5 half NS most commonly given. In the hospital, again, you're going to see normal saline given quite frequently, or D5. These are the most common two isotonic solutions that we give. Occasionally, we do give some hypotonic solutions, and most of the time that's going to be your half normal saline. So the little cartoon here just illustrates the top 5 IV solutions you're going to see given in the hospital. Normal saline, Ringer's lactate, D5W, D5 half NS, and D5 NS. So the next few slides are just some formulas related to the calculation of IV flow rates. When using an IV pump, you want to do your milliliters an hour, which is going to be your volume in milliliters over your total hours. That's going to be your milliliters an hour. Feel free to use any formula that you find in DoseCal 360 or ATI to assist you with calculation of your IV flow rate. When you have IV flow rate using a pump for milliliters an hour, you're going to have to convert your minutes to hours. Just keep that in mind when you're doing your calculation. Once again, you can use any formula from DoseCal 360 or ATI to aid you or assist you in calculating your IV flow rate for those less than an hour. Drops per minute is a standard formula. Volume over time in minutes. Multiply by the drop factor or the drip factor, whatever you have available or whatever is ordered. Once again, feel free to use whatever method DoseCal 360 or ATI has for you that you're comfortable using. And this concludes my lecture on IV therapy. Thank you for joining me today.